Hi there. Pandemics are not just health issues, but economic ones too. COVID-19 has shown what havoc a pandemic can wreak on an economy. Health policy is economic policy. Indeed, one of the key elements that foreign investors assess in a target country before they invest is a robust healthcare system. A country, therefore, needs to develop a robust and multi-layered healthcare system capable of handling not just mundane everyday health issues, but of also responding to emerging crises like pandemics. It should be resilient and persistent. Today I want to talk about one aspect of this preparedness. But before I continue, do visit our website where I curate news and publications from international financial organizations and world central banks. Topics cover a wide range of financial and economic issues that affect individual countries or the world economy. For instance, COVID-19, inflation, or the war in Ukraine. Please also subscribe to this channel and be informed whenever we publish a new video. The concept of Barefoot Doctors originated in China. Although the Barefoot Doctors program was institutionalized after 1965, following Chairman Mao's healthcare speech and subsequently integrated into national policy, Barefoot Doctors had been around for a few decades before then. What are or were Barefoot Doctors? According to Wikipedia, these were farmers, folk healers, rural healthcare providers, and middle or secondary school graduates who received minimal basic medical and paramedical training and worked in rural villages in China. Their purpose was to bring healthcare to rural areas where urban trained doctors would not settle. They promoted basic hygiene, preventive healthcare, and family planning, and treated common illnesses. Barefoot Doctors continued to introduce Western medicine to rural areas by merging it with Chinese medicine. With the onset of market-oriented reforms after the Cultural Revolution, political support for Barefoot Doctors dissipated, and healthcare crises of peasants substantially increased after the system broke down in the 1980s. Indeed, the success of the Chinese Barefoot Doctors program was part of the inspiration behind the World Health Organization, WHO, and its member countries adopting the Alma Ata Declaration, or Primary Healthcare Initiative, in 1978. It is clear that, particularly for emerging and poor nations, a program of Barefoot Doctors can radically change the health and mortality outcomes for a nation. The program could be further enhanced with Cuban-style home visits. A policy and system of Barefoot Doctors can address a number of issues for a nation, such as 1. Rapid production of primary healthcare providers. 2. Cost effectiveness at the training level. 3. Cost effectiveness at the provision level. 4. Assistance with adherence to treatment regimens for debilitating illnesses, including HIV/AIDS, diabetes, TB, etc. 5. Rapid improvement of the health status of the poorer sections of the population. 6. Reduction of unemployment in poorer areas, such as rural areas, townships, and informal settlements. The need and potential benefits of Barefoot Doctors are particularly apparent during a pandemic such as COVID-19. If many emerging economies had Barefoot Doctors, the response and therefore outcomes to COVID-19 would have been radically different. Not only the population as a whole would have been better mobilized, the healthcare system would have had people in closer proximity to communities in townships, informal settlements, rural areas, and the homeless to immediately inform and encourage adherence to health guidelines, such as hand washing, social distancing, mask wearing, and undertaking testing. Given the experience of the lack of preparedness for COVID-19, it is perhaps time to consider a strategy to deal with emerging and future health crises and pandemics. In this regard, a system of barefoot doctors would greatly enhance a country's preparedness while being beneficial on an ongoing basis.